Good evening and welcome to AUA's Surgical Management of BPH and updates from the AUA Clinical Guidelines live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our program. The AUA is accredited by the ACCME and designates this Internet Live activity for a maximum of 1.5 AMA PRA Category 1 credits. Course handouts from the presentations have been made available to you. Please visit the AUA University to access the handouts. Evaluations are very important to us. Course evaluations and CME credits will be administered electronically on AUA University immediately following the webinar. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in positions to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit the AUA University to view Faculty and Education Council disclosures. The AUA would like to thank Olympus Corporation of the Americas for providing an independent educational grant in support of this webinar. Coding advice given during presentations are the option of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. Please note that course participants are prohibited from using or uploading content you accessed through this activity into external applications, bots, software, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. Finally, I'd like to extend a special thank you to our course director and AUA Associate Secretary, Dr. Jaspreet Sandhu, for his time, talent, and expertise in developing this program. I will now turn the webinar over to Dr. Sandhu.
Thank you so much, Pia, and good evening and welcome to the AUA's good evening, good afternoon, good morning, wherever you are. Welcome to the AUA's the Surgical Management of BPH and updates from the AUA Clinical Guidelines live virtual course. And I'd like to thank the outstanding faculty. I will introduce them formally in a few minutes, but Peter Gilling, most of you know, is from New Zealand. Amy Krambeck is from Chicago, and Chuck Welliver is from Albany, New York. As the AU already mentioned, we hope you will actively engage with us throughout the program. Please interact with us and feel free to ask questions of the experts at any point using the chat box on your screen. And we will answer those questions throughout the webinar, but we may also have some time at the end to address those. So let's get started. Our goal is stated here. You guys should have all gotten that. The AUA is launching an educational initiative for those clinicians and other healthcare professionals involved in the treatment of BPH. Based on the documented needs assessment for additional education focused on newest technology and procedures related to surgical management of BPH, as well as the newly amended management of lower urinary tract symptoms attributed to BPH clinical practice guidelines, the AUA has developed multiple education interventions to improve the ability of urologists to take care of patients with BPH. This is what this particular webinar is all about. We will go through some early didactics about how to manage patients. And then these are the learning objectives. You should have the learning objectives with you. So I'm just going to put these up for just a second. But basically what this webinar is going to consist of is a few didactics about what the AUA clinical practice guidelines is. And then towards the end, we'll talk about a few of the surgical modalities that are available currently. And with that, I'd like to welcome our faculty. As you know, I am Jaspreet Sandhu. the Associate Secretary for the AUA. My other role is directing functional and reconstructive urology at Memorial Sloan Kettering. I would like to introduce our esteemed faculty. First up is Peter Gilling from New Zealand. Most of you who know BPH know Peter Gilling. He's one of the early pioneers of a lot of the new technologies, including HoLEP and robotic water jet therapy. He practices at Bay of Plenty in New Zealand. Next is Amy Cranbeck. Amy Cranbeck trained at the Mayo Clinic and then did a fellowship with Lingaman in Indiana, and is currently a professor of urology and director of endourology at Northwestern University in Chicago. And finally, Chuck Welliver is from Albany. He trained at Albany and did a fellowship in men's health with Dr. Toby Kohler in St. Louis, and then is now directing men's health at University of Albany. So welcome, and we will try to make this a little more conversational, but let's get started. So segment one is exploring the who, what, and why of AUA BPH guidelines and how it affects clinical practice. Methodology, for those of you that don't know, the methodology of AUA practice guidelines is set by a group of methodologists who are not necessarily urologists, and then the statements are done with the help of urologists. So for the surgical management of BPH, the Minnesota Evidence Review Team searched a whole host of databases between January 2007 and September 2017, so roughly a 10-year period. Data utilized to generate these statements are based on results from what the panel felt were acceptably performed randomized controlled trials or comparative trials for each technique compared to TURP or sham. To provide some reference to the clinical efficacy and side effect profile for the procedure discussed in these guidelines, clinical statements are made in comparison to what is generally accepted as a historical standard. That, in this case, being TURP. Monopolar and bipolar were considered the same. Supporting text, which is found within every guideline, could include any publication found by the evidence team or panel members. So just to reiterate, all these clinical practice guidelines by the AUA are available at auanet.org. You can click on guidelines and go to the particular guideline you're interested in this case, BPH, and they will have all the statements as well as a supporting text. So first-hand clinical accounts and the proper application in the role of guidelines in day-to-day practice. We'll now move on to this segment, and I'm going to ask a few questions after I go over these statements. So these are statements directly from the guidelines. Guideline Statement 6 says clinicians should perform a PVR, post-void residual assessment, prior to intervention for LUTS or BPH, LUTS due to BPH. Guideline Statement 7, clinicians should consider uroflowmetry prior to intervention for BPH. Number 8, clinicians should consider pressure flow studies prior to intervention for LUTS BPH when diagnostic uncertainty exists. So those are different levels of certainty in terms of what tests you should do. You should definitely perform a PVR. The other two are optional. Uroflow you should consider, and pressure flow or urodynamics only when diagnostic uncertainty exists. This is the algorithm, which is also available at auanet.org about basic management of LUTS in men. And the bottom line, you're trying to differentiate between overactive bladder and bladder outlet obstruction, essentially. And if you have bladder outlet obstruction or symptoms of bladder outlet obstruction, you tend to go towards medical and surgical management. And if you've got primarily overactive bladder, you go towards overactive bladder management. Another statement within the guidelines, Guideline Statement 5, said clinicians should consider assessment of prostate size and shape via transrectal or abdominal ultrasound, cystoscopy, or cross-sectional imaging. That's MRI, CT, if such studies are available, prior to intervention for LUTS BPH. All these statements that I've stated so far are clinical principles, meaning they're not based on evidence, but it's something that we as urologists thought, at least in the panel, thought should be done for everybody. So this is relatively new data, and some of this determines what kind of treatments can be offered. We'll talk about that in a few minutes. And there are two other algorithms within the guidelines. One is a trial of medical therapy. This is the medical therapy guideline. And the next one is a trial of the surgical management of lower urinary tract symptoms attributable to BPH. This is the surgical management guidelines. Both of these, again, are available at the auanet.org website. So before we go further, I'd like to ask a few questions. So, Dr. Welliver, Chuck, can I ask you a question? How do you utilize the components of the algorithms in day-to-day practice?
So I really think about it as the initial visit and then follow-up visits. The initial visit, you have a couple absolutes: history, physical, you should get a urinalysis, or even higher than that recommendation, and an IPSS score. You need to know where you're starting. Urinalysis is helpful to potentially exclude a bladder cancer or an infection as a possible risk. At that visit, I also like to really talk about the chief LUTS complaint. What's the one thing you could change about your urination? Because I think it helps you break into that algorithm of nocturia or more of a blend of symptoms right away. At follow-up visits, that's where I start to bring in the Euroflow and the PVR again and again an IPSS. You really need to assess if they're actually improving with the treatments that you are putting them on or the procedures you have done. Yeah, and one of the important things in the guidelines also is that you need to reassess patients in the 4 to 12 week region. We're really not doing anybody help when you just put them on an alpha blocker and tell them to follow up in a year. That's really not checking in on how the treatment is going and moving them in a good direction.
Got it. I appreciate that. Amy, how does imaging or understanding the size or shape of the prostate influence your decision on which modalities you would offer the patient?
Well, I would say in this day and age, it's probably one of the most important tests you will do as a urologist. When you have so many different therapies, such as thermal water therapy, prostatic urolift therapy, aquablation, TURP, HOLEP, you need to know the size and configuration of the prostate. So I think it's pretty obvious that I do mainly HOLEP, so it's a size independent surgery, but I need to know how big it is to know how long the surgery is going to take. If I have a patient that's really interested in preserving their ejaculation, then I need to know how large their prostate is so I know to refer them to, if they're a candidate for thermal therapy, or if they lack a median lobe, potentially they could explore Urolift. So the configuration of the prostate is extremely important these days, and it's surprising how often we see sizing and imaging omitted in the workup.
That's a great point. We often see patients who come in for either water vapor thermotherapy or prostatic urethral lift with very large prostate. So if you have that information, you should absolutely use it. Peter, if a patient comes in with an indwelling catheter, how does that affect your decision making on the modalities you offer them?
Well, I think it's important to establish that it is bladder outflow obstruction rather than bladder dysfunction from some other cause. And it's important to establish whether you're dealing with acute or chronic retention with this undifferentiated patient. But assuming that it is acute retention, the guideline does speak to the use of alpha blockers in terms of the trials avoiding, and suggests that at least 3 days of an alpha blocker before a trial avoiding. I think it's important maybe to have a couple of trials avoid before you consider therapy. Obviously, if you've got a patient in retention, you'll be looking to do a procedure that removes tissue acutely so that you can disobstruct that patient rather than something that causes coagulative necrosis or readjusts the tissue. So I think it affects things in a number of ways, but particularly in terms of what type of treatment you employ when we have an array of different minimally invasive and resective techniques.
Got it. So you mentioned bladder function. How essential is understanding of bladder function prior to procedural intervention? Chuck.
When we think about procedures, you really think about risk and benefit. So the risks are kind of patient factors, need for anticoagulation, prostate size. Some of it is the modality you pick, more invasive procedure. is going to have more risk versus a missed may not have as much. I think bladder function helps you build up the benefit side of that seesaw. So a patient that you have fairly sure their bladder works, they're going to benefit from the procedure. Where if you have a patient like Peter talked about who has a catheter in and you're not sure if it's a bladder dysfunction or a prostate issue, that really helps you figure out if that surgery is going to have benefit. If they have a dead bladder, it's less likely to work. If their bladder works great, they're almost for sure going to be catheter free after the procedure. So I think it just helps define benefit per procedure and that risk benefit.
That's a good point. I mean, it's more prognostic in my mind, because if a patient comes in with a catheter and wants to get rid of a catheter, you do a procedure regardless of what the urodynamics show. Amy, you have shown before that even with a reflexic bladder, you can get patients to void with a properly done outlet obstruction reducing procedure, correct?
Yes, and I do very little urodynamics, but the time that I will do urodynamics is when it is a patient that surgery may be risky for them. Like they may be very ill, they have a neurologic condition. It's where the risk of surgery would outweigh the benefit. So I definitely want to do baseline urodynamics in that situation to know if it's worth putting the patient through it. But on that end, especially anatomic enucleation, you remove so much tissue that it requires very little bladder function. And even some patients can void by Valsalva if they're highly cooperative.
Makes sense. A little like a radical prostatectomy patient. So let's move on. Communicating patient expectations regarding BPH treatment and maintaining a patient-centered focus. You've heard a lot about risks and benefits and shared decision-making. The guidelines talk about that. And one of the things they talk about is what Chuck alluded to before. Guideline Statement 3 says patients should be evaluated by providers 4 to 12 weeks after initiating treatment, provided adverse events do not require earlier consultation to assess response to therapy. Reevaluation should include the IPSS. Further evaluation may include a post-void residual and uroplometry. This is also a clinical principle, but a couple of points for IPSS and IPSS-QOL. Reviewers determined that statistical significance of the effect of intervention versus control, but define clinical efficacy based on whether the mean or median effect between intervention and control exceeded thresholds for clinical significance. Clinical significance was defined at IPSS difference of greater than 3 points or a quality of life difference of greater than 1 point. And another statements, there's 2 statements I like to focus on. That was one. The second statement, clinicians should inform patients of the possibility of treatment failure and the need for additional or secondary treatments when considering surgical and minimally invasive treatment for LUTS BPH. And this is also a clinical principle, but reported rates of retreatment are influenced by both the duration and the completeness of follow-up. So it's very important to note when you're looking at reports, whether or not what their retreatment rates are and what the duration and completeness of follow-up is for those studies. Which brings me to a few more questions for our panelists. Amy, how vital is it for urologists to track their own results, both objectively, PVRs and flow, and subjectively to reevaluate their patient selection and surgical approaches?
Well, I think it's imperative. I think every urologist should take a step back and look at their results, because what is published is the most absolute ideal situation and ideal patient. And your patient population may be totally different and you're not getting the same outcomes. So if you don't take the time to step back and look at your results objectively, then you lose sight of the forest from the trees. Like you just keep doing the same thing over and over again and maybe getting suboptimal results. Maybe you need to change your technique. I truly think it's paramount to get not only the IPSS score, PVR, flow, and I also get the Michigan incontinence score, just so you can objectively assess where they were before they got to you and where they are after you treated them.
Interesting. So the incontinence score, most of us don't get. OLEP people sometimes do, and radical prostatectomy people always do. But that's a very, but it's very important to get the IPSS and validated questionnaires. Peter, how do you counsel a patient regarding secondary procedure or return to medical therapy for the modality you have chosen?
Yeah, I think it's very important as part of your informed consent process for each of these approved treatments for lower urinary tract symptoms. I mean, there's a wide discrepancy between the retreatment rates for something like HOLEP, which might be less than 1% at 3 to 5 years, compared to PAE, which has a retreatment rate of 30 to 50% at 5 years. And for my patients, they're way more interested in retreatment rates than they are, for example, retrograde ejaculation, which for most of them is of no interest whatsoever, but it is one of the defining features of a whole lot of the minimally invasive therapies. The retreatment rates, I think, are sort of fundamental to bits of information to allow patients to make an informed decision about which modality they will subject themselves to.
Those are all very good points, and we'll talk about that in a few minutes. Chuck, what if a patient really wants a therapy that you feel will not render them free of medical therapy or puts them at a high risk for secondary surgical procedures? So they come in wanting something which you feel is not appropriate. What do you say to them?
It's certainly not my favorite clinical visit, but patients have different risk tolerance, and part of finding out and finding common ground with them is figuring out what their risk tolerance is. A patient that really wants to maintain ejaculation, a miss that maybe doesn't get them there, as long as they're understanding that they may need something else done in the future, I think is reasonable. And there are very few myths that cross off future procedures in general, just kind of the way it's structured. So I think it's reasonable, but yeah, it's not my favorite visit.
So, I mean, you guys have all mentioned that you should find the patient's preferences. What is a patient's preference for retrograde ejaculation? What's their risk tolerance for urinary incontinence? What's their risk tolerance for secondary procedures? All these are extremely important, and a lot depends, I think, Amy, you touched on this, on your patient population, because Peter's population may not have anybody who cares about retrograde ejaculation. I thought my population was like that too, but all of a sudden, when you ask them, patients actually do seem to care. So I don't know what your thoughts are. I mean, some of this is, yes, it's your patient population, but some of it is, patients that you ask questions that you never thought of before. Amy, what do you think of that?
Yeah, I think you touched on a really good point, which is retrograde ejaculation. I think I just realized this year that many patients, even highly educated physicians, don't know the difference between retrograde ejaculation and orgasm. So they think that they will never be able to orgasm again. And once they understand the difference, it becomes less of an issue. And so, over the last 18 months, I think I've changed my discussion with them to first explain the differences. And then that really takes that off the forefront. Not every patient, but the younger patients, or maybe some cultural issues, they still are very concerned about ejaculation. But, my patient population, most of them are over 70 or 80, or even in their 90s, they really just want to urinate again and get a good night's sleep. So you really have to talk to your patient. You have to educate them first on the subject, and then you have to talk to them about what their true needs are.
And have you guys noticed a change? So if your discussion changed, partly because I suspect people were asking more about retrograde ejaculation, partly because of the advertising of all these modalities that quote preserve ejaculation. So makes me wonder if that's the case, is it the counseling that's changing or the actual patient population that's changing? Peter, what do you think of that?
Well, I'm sure a lot of the information that patients see now around minimally invasive therapies is company driven, and often the retreatment rates are much higher for those modalities, but retrograde integrate ejaculation is preserved. And if you read some of the company's literature, you might think that that's the most important thing in the universe, but not to my patients. And particularly, as Amy says, if you break it down to orgasm, appreciation of orgasm, and erection, less fluid for them is completely irrelevant. And as I say, it might be that New Zealand men are different, but I don't think so.
What do you think, Chuck? I'll give you one last comment.
I think an important point is they just worry about there's going to be some sexual dysfunction. And Amy's point is excellent. Note you have to differentiate orgasm, ejaculation. Patients are used to those going together, but they are definitely different processes. You need to talk about erections too. There's a lot of misinformation and a lot of room to be made with regards to medical literacy as you talk to these patients about procedural options.
That's awesome. So the bottom line, you got to talk to your patients and discuss the procedures with them and the outcomes. So let's pivot. We'll wrap up this first portion of tonight's webinar by reviewing pivotal studies of minimally invasive surgical treatments for BPH. So the key thing about the new amendment is the panel recognized there are some legacy technologies that have been historically used and are currently FDA approved, but have very limited newly published data to be able to comment on their efficacy. So the legacy technologies, at least according to the amendment, were TUNT, or microwave therapy, and TUNA, transurethral needle ablation. Both of those have been lumped together in legacy technologies. Some may say TURP should be a legacy technology, potentially, because there's very little data on it compared to itself. But pivotal studies are hard to define in the surgical space as compared to medical. And guidelines of size recommendations that are based on published studies, yet those procedures are often employed in patients outside these parameters and often are FDA approved outside these parameters. So the guidelines are just, as has been stated before, the guidelines are strictly evidence-based. So published evidence is what determines the guidelines. So based on that, Amy, how do published trials and randomized controlled trials affect your decision-making?
Well, I think level 1 evidence is absolutely necessary in our field. And so I rely heavily on level 1 evidence, but I also look at the source of the study. Was this funded by a company is one thing, an unrestricted grant for you to evaluate a technology, but then actually completely funded through the company, and the data handled by the company is a different beast all in and of itself. So you have to look at the source. You also have to understand what they're comparing to. Are they comparing it to the gold standards such as TURP? Dr. Gilling has done some amazing studies comparing whole up to TURP, and we base a lot of our decision making on those studies. Or were they comparing it to nothing? A lot of these studies are compared to absolutely nothing, not even medication, but to nothing. And so you need to be critical of the data, and if the study is done well, then absolutely use the data to guide your practice, but look at the fine lines and the details of the study.
Peter, how do overall randomized control trials matter to you in your practice?
Absolutely. Just as Amy said, we've got to remember that the pivotal trial is an FDA construct from 20 odd years ago, and they've been refining the inclusion-exclusion criteria and the study design and so forth. But it's the primary evidence of safety and effectiveness, but it is to support a marketing submission so that the FDA deems it to be safe for the population and so forth. But remember that these RCTs, they minimize selection bias and they control for confounding factors, so you get the purest understanding of the treatment effect and the safety and the side effects, and it's monitored by external people. I mean, it's as good evidence as you're going to get for the actual the treatment itself in terms of what it's capable of and what the downsides are. And they're done honestly because the FDA is peering over everybody's shoulders. I love the pivotal trials and the foundation of my practice.
Chuck, what would you say? Do you use randomized controlled trials in your practice?
I mean, to the best you can. The inclusion criteria for those don't meet every patient. A lot of patients with over 300 milliliters in their bladder are excluded from a lot of those trials right away. So if you're managing a patient that's above that, you're kind of out on a limb to begin with, just as an example. It's something you should certainly be aware of and figure out how to apply to the clinical situation you're in, but not every patient was included in those studies.
Yeah, and I'll say, a lot of surgical techniques have not been subject to randomized controlled trials. Most of the surgeries we do have not been subjected to randomized controlled trials. That said, you're absolutely right. It gives us the best data to compare techniques, and it gives us the best data to compare techniques in a very strict population. So if you have somebody in that strict population, you want to talk to patients who are very well educated, this is a great way to talk to patients about what is better than other things. A randomized trial is, as you stated, Amy, is level 1 evidence. That's as good as we get. So if you have randomized trials about certain techniques and you have patients in front of you who you're talking to about those techniques, it certainly helps you to talk to them about it, particularly the educated patients that all of us see these days. And those that come with ChatGPT, et cetera. So they know a lot more than we do. So that concludes our panel discussion today. Thank you for joining us, and enjoy the rest of your morning, evening, or afternoon, wherever you are. Thank you.